Good afternoon and welcome to Case 6 Survivorship. I'm Dr. Jennifer Klemp, a professor of medicine in the Division of Medical Oncology at the University of Kansas Cancer Center. And today we are lucky to have a panel of experts, including Dr. Ann O'Day and Lori Ranallo, where we will dive a little deeper into the comprehensive care of cancer survivors. One of the most important things for us to think about as we're talking about a survivor is how are we defining that individual? And we are going to use the traditional definition from NCCN and other organizations that a survivor is anyone from the time of diagnosis through the lifespan. So that includes all of those issues that you think about with treatment planning, acute when they're ongoing during treatment, and then post-treatment. That has become quite comprehensive when you look at some of the guidelines that are out there. Once again, NCCN has provided us with sort of this laundry list of not only looking for issues related to the current disease, but what about new primaries or recurrence? And what about all the potential late effects? So I'd like to start out by asking Dr. O'Day, when you're thinking about this comprehensive assessment, how does it look in a busy breast medical oncology practice?
Hi, I'm Ann O'Day, breast medical oncology at University of Kansas Cancer Center. Thank you, Jen, for moderating today. I think what we try to do is look at each patient and sort of where they are in their own cancer journey, whether they come to us from the time of diagnosis or whether they maybe move into our clinic later on after they've completed treatment. We try to do an overall assessment of where their health is now and what their goals are for their own health. We try to think about things like what their quality of life is in terms of hormonal balance or menopausal status. Oftentimes it is the changes that occur through cancer treatment that drive a woman having a transition from premenopause or perimenopause to menopause. And that can be a very difficult transition. And we want to make sure that women have all the tools possible to help support them through that transition. That can be particularly difficult for them if they're doing that in the setting of a breast cancer diagnosis as well. We also want to think about things like their bone health. We know that oftentimes the treatment that we offer for patients with curative intent or otherwise can have an impact, sometimes a negative impact on patients' bone health, whether that's related to hormonal status or otherwise. So that's something that's very important for us to assess. We want to assess cardiac risk factors because we know that often cancer treatment can have an impact on patients' cardiac health, and that can be dependent on their cardiac health, sort of how they started or how they sort of came to us and what their goals are moving forward. We absolutely want to think about their comorbid conditions. So if patients do have, for example, uncontrolled diabetes, we know that that is going to impair our ability to help them be cured of their cancer. It's going to increase the risk of recurrence of their cancer. So we want to do everything we can to try to help them make sure that all of those comorbid conditions are controlled as well. So we also want to make sure that we look at their family history at the time that they come to us, but also as it evolves over time, because we know that that there are a lot of our patients that are going to have genetic or predisposing factors. Maybe that's what caused them to develop or predispose them to develop their breast cancer. And maybe they're at risk for other types of cancer. Maybe their family members are other risk for other types of cancer. And so those are things we want to make sure that have been assessed. And if they weren't assessed at the time of their initial breast cancer diagnosis, we want to make sure that we update those and continue to update those as they continue. You know, when we first when I started as a fellow, we were testing 2 genes. Now we're testing 30 and more genes for each patient. And so oftentimes we can find answers for families as to why they may have developed this breast cancer, or others in their families may have developed breast cancer. So those are all things that we kind of try to sort of think through. And I'm very lucky that I have a team of nurses to practice with and nurse practitioners that do a fabulous job working in a sort of a combined clinic setting and also an independent clinic setting like Lori does in our Breast Cancer Survivorship Center.
So I think, Lori, as you heard, kind of that overview from Dr. O'Day, you're the baton where, you're the handoff. And a lot of those things you do both in tandem with the providers, but also independently. And could you give just a couple examples from some of the things that she highlighted of how that then would look in your clinic, and how you would take some of those topics and assess and educate and manage a survivor?
Absolutely. So thank you, Jennifer and Dr. O'Day. I'm Lori Ranallo. I'm a nurse practitioner in breast oncology survivorship and prevention at the University of Kansas Cancer Center. I'm so happy to be here today. And as Dr. O'Day was discussing breast cancer and the trajectory of their disease, certainly where my care comes in is in that follow-up continuity practice. So most of the patients that I see have been discharged from medical oncology or transitioned to survivorship. So when they arrive in my clinic, I do all those things that Dr. O'Day just spoke about: a complete physical review, symptom management. But I think more than anything, what I'm seeing in our practice is the psychosocial aspects, the financial toxicities of their treatment, and just the things that they've kind of put on hold or on the back burner while they've been fighting through their cancer treatment. So oftentimes bone health is a big issue. We need to address that cardiac issue again and over time, as well as reviewing their family history, and just menopausal symptoms. That's probably one of the biggest things that we deal with.
And I feel like sometimes, your clinic ends up, and we just heard from Dr. Stecker. So if those of you didn't hear her talk, please go back and listen to that, because it does highlight kind of that comprehensive, in-depth need for assessment, education, and ongoing management. But sometimes I feel, Lori, that you have like half your visits are menopausal symptom management, because a lot of that has been sort of left sort of unnurtured during their treatment, or hasn't been the biggest priority. So you do focus a lot on that. And do you work with other providers like Dr. Stecker or like other providers in the community?
Absolutely. So definitely those issues of body image, lymphedema, sexual health, pain, chronic pain, fatigue. So I utilize all the specialists in our system. I refer to psychology, I refer to onco rehab, I refer to gynecologist. Just getting that patient back to some sort of normal baseline, or as good as we can post-treatment.
Great. Those are great examples. And I know we put together some slides to be kind of talking points for us today, because I really think this experience that you'll hear from Dr. O'Day and Lori is very valuable as we think about how to conceptualize our survivors. There are resources out there. Once again, everything that you just heard is outlined in the NCCN guidelines. This was just freshly updated, so feel free to review that and use that as sort of your primer. So we thought we'd put together kind of an example case, and as you can imagine, Sheila is going to have a lot of survivorship issues that will allow us to sort of talk through that a little more. So she's a 56-year-old postmenopausal female. She was diagnosed with an invasive ductal cancer a little over 5 years ago. She had a standard therapy, but it does include the fact that now she's receiving longer term therapy, including she received a year of Herceptin. She's on an anti-hormone therapy. She did have genetic testing, but as Dr. O'Day said, it was very limited testing. And so this will all go into sort of how we think about Sheila going forward. So since then, Sheila has unfortunately gained some weight. She's become more sedentary. She has to maintain her job, to maintain her insurance. She has quite a few of those side effects that we talked about from menopausal symptoms, including hot flashes, mood swings, and sexual side effects. She has arthralgia and sort of aches and pains, which she complains keeps her from sort of exercising to a decent level. She's had some persistent skin changes post her radiation. She's worried about lymphedema, and she was genetically tested in a survivorship clinic by someone like Lori or Dr. O'Day, and now she's found to have a CHEK2 mutation. So what do we do about that and her daughters? And unfortunately, she's also separated from her partner, and now they are divorced. So this is seems extreme because we've sort of put all these potential late effects into this one case, but she's really not that extreme. And when you think about this case, Lori and Dr. O'Day, you know, I know we've thrown a lot in it, but how would you rate this in regards to, you know, similar patients or things that you would experience from the average patient in your clinic?
I think this is very normal. I would say this isn't extreme at all. This is just the average, you know, the average patient that we see. I shouldn't say it's the average patient. It's the average situation or sort of culmination of factors that lots of our patients are dealing with. You know, the breast cancer treatment is not a short thing, you know, and so one of the things I love about our practice is that we get to know patients over many years of their life. But as they go through those years of their life, they go through inevitable hormonal transitions, sometimes because of our treatment. They go through body image issues, again, sometimes because of our treatment, an evolving landscape of genetic factors, which can, you know, depending on the person's situation and their family support, sometimes that can be difficult. Sometimes people are trying to reach out to estranged family members to let them know about hereditary predispositions, or I have moms trying to help their daughters navigate these hereditary mutations, those types of situations. And then, you know, we see patients that have an evolving support structure all the time. You know, we might start out with a supportive, loving husband, and at the end of the 10-year journey, that person may not still be there. And so that is something that we just have to try to help support our patients as they go through all of these changes and transitions in their life. And I think that the weight gain, we started off with that. And I will say that that is something that's very common. We know for breast cancer survivors, not only because of the treatment that we give, and because of the stress that's associated, you know, with the diagnosis and treatment of breast cancer, but also if you just look at the average age of women diagnosed with breast cancer, you know, in their 50s or 60s, this is a time when there's substantial metabolic changes and hormonal changes that lead to inevitable sort of weight gain if there isn't a tremendous amount of help and focus on that. And so we know that that will increase a risk of that person's recurrence. So we really have to make sure that we help them with all of those things. So all of these issues, I would say, are very, very, very normal in things that we talk about every single day.
And Lori, would you like to add anything to that? Because I think that as you're seeing a lot of these women, even in longer term survivorship, those are still persistent issues, and you're still sort of helping to manage and co-manage those issues.
Absolutely. So a few things that really stand out to me in this situation is a lot of these symptoms can kind of get bundled together, and we might call them menopause. But are we having thyroid dysfunction, or is the patient anemic, or is the patient depressed? And I think that's the beauty of our continuity clinic, because I spend a little more time than our oncologists can. I devote a longer time frame for those visits, and so we get to really start to peel the layers of the onion. So, you know, are you depressed? Let's get you some help with a psychologist. Are you anemic? Do we need to get your, you know, some iron studies and get some iron started? You know, just again, just sorting through all of those symptoms, because I think patients have been bundled pretty often, and I think it's refreshing to kind of separate those things and really dive down into what's causing the decrease in quality of life.
Absolutely, and this becomes the priority. Whereas I do think that when you guys are so focused during treatment, it's not that these issues aren't important, but there's so many important issues. And during the treatment, obviously that is getting patients through that phase. So there's a comprehensive list that we need to be thinking about as we see these patients. And we sort of summarize this here for Shelia, of just showing what types of things could be issues for her. They may not be, but that also means, just like Lori said, is we really need that village and being able to co-manage those issues. So just real quick, and I know we just heard from Dr. Stecker, so I don't want to spend too much time, but the next two slides are a little bit more in depth about kind of how hormones work. And Dr. O'Day, do you just mind describing real quick, when because not everyone works in breast cancer, but estrogen is sort of the good, the bad, and the ugly. So when we think about it in regards to cancer, how does that look? And then we'll flip to the next slide, which is what happens to our sort of menopausal symptoms.
Sure. So we understand that estrogen as our primary, female hormone is the driver of about 80% of breast cancers. And so, we know that there's a tremendous amount of focus in how we can sort of modulate or block estrogen in the treatment of breast cancer. Oftentimes women will come to us at the time of their diagnosis and they're taking hormone replacement because they were struggling with menopausal symptoms just through the natural course of menopause. And when they receive a diagnosis of breast cancer, that means that we sort of are recommending that they often stop those kind of cold turkey. And that can be really tough because we know that estrogen does have definitely an impact on our central nervous system. It helps with memory, cognitive function, multitasking, word finding, sort of all of those higher functioning abilities that we think about. I describe to patients as our ability to keep all those balls in the air. It does take a lot of estrogen to be able to make that happen. We know that it has an impact on our cardiovascular system in terms, especially when it comes to our vascular system, our arterial elasticity. We know it has an effect on our reproductive system. We know that without estrogen, we'll see atrophy of the vaginal epithelium. We see often urinary changes, frequent bladder infections, all of those sorts of things, sometimes painful intercourse, loss of sex drive. So all of those things can be impacted. And then of course, of our musculoskeletal system, not only does estrogen sort of make us feel good and make our muscles and joints sort of work better and just feel better, it has a very positive impact on our bone density. And so when we go through menopause, whether that's at sort of a natural age of around 50 or whether that's earlier, that can have an adverse impact on our bone density. We reach our peak bone mass as women when we're about 18 years old. And from that time on, it's declining. So unfortunately, we're sort of fighting a downhill battle, I guess. So we really have to make sure that we do everything we can to focus on keeping ourselves strong, with resistance exercise and to help build, not only to help our cognition, to help our energy balance, or maintaining our weight, but to help our bone density. And we know that estrogen can have an impact on increased risk of certain types of cancer, particularly breast cancer, and then also endometrial cancer, particularly if there's unopposed estrogen, that can increase the risk of endometrial or uterine cancer. So estrogen does lots of great things, but also there are those things that can have a negative impact as well. When we sort of flip that and we have the anti-estrogen, the estrogen receptor modulator or sort of estrogen receptor blocker, then what we see sometimes is we can see adverse impacts on cholesterol. Sometimes women who've maybe had borderline high cholesterol will start to have elevated cholesterol. Sometimes patients may even suffer a cardiac event or a cerebrovascular event. In terms of reproductive system, when we have estrogen receptor blockers or modulators, we often will see atrophic vaginitis develop, which can lead to painful intercourse, which can obviously impact and decrease sex drive, urinary issues, as well as incontinence. We also know in terms of the musculoskeletal system, we can see osteopenia and we can see just joint stiffness and aches in the forms of arthralgia. So these are all things that we have to make sure that we sort of help women with, because all of those things have the ability to impact not only our length of life, but our quality of life. So these are very important issues that we have to make sure that we sort of maximize for our cancer survivors, because we know we can't just do the easy fix and just give them lots of estrogen. So we have to work really hard on maximizing each of these systems in the absence of estrogen.
And so this really does bring into that thought of not only having a lot of tools in your toolbox to be able to deal with which of the issues that the patient maybe had a comorbid or a borderline situation at diagnosis, but what has the treatment accelerated? What is the weight change accelerated? So there's a lot of baseline acceleration, a lot of things happening that means not only you have to have a lot of tools available, but you do have to have sort of that kind of multidisciplinary team that you can depend on to help with this co-management. And the overall goal is obviously the treatment of the cancer. So weighing out those pros and cons, I just wanted to sort of bring in where it becomes, I think, even more challenging for you guys is that as you're thinking about those most common complaints, sometimes we have good solutions, sometimes we don't. But are there sort of tricks to the trade that as you hear, like Lori, you said, when you're thinking about fatigue or depression, you know, how would you tackle that in a longer term survivor, which can obviously impact her her adherence to her therapy too?
Yes, so again, just peeling those layers of the onion. Are they sleeping well? Have they developed sleep apnea? Are they deficient in a vitamin? Is their thyroid function off a little bit? So addressing the medical problems are very important. And like you said, having that toolbox, but also having resources for experts that you can refer to, I think is very critical for someone in my position.
And it does affect adherence, because if you're not
That's right.
really feeling well or you have some negative side effects, you're not going to be as likely to take your medication. So I thought that this was an interesting slide. This is a recent study, actually from a nursing journal, where they highlighted sort of all these different therapies that are potentially out there. So do you use any of these, Dr. O'Day or Lori, as you're thinking about managing hot flashes? And this was as I said, a recent meta-analysis, which came out in 2021, but I thought it was kind of helpful at just seeing what effectiveness that each of these therapies had in regards to hot flashes.
Right. And I completely appreciate, you know, Lori's insight into this, because oftentimes it isn't just as simple as hot flashes. You know, it's what's triggering the hot flashes? Is it anxiety at work? Is it that you're not able to fall asleep? Is it that, you know, you're having, you know, other situations which are really triggering the hot flashes? If that's the case, if it is more of an anxiety based situation, then I find that using an SSRI or venlafaxine is going to be more helpful than something, for example, like than gabapentin, which is going to be more purely helpful for the hot flash per se. If the issue is primarily hot flashes that create an inability to sleep, then I find gabapentin is really helpful, because that can often help people fall asleep. So really having to understand what it is about the hot flashes, the pattern, how often they're happening. Are they happening during the day, during the night, all the time? Are they triggered by certain situations or stressors? These are all, I've used every single thing on this list. It just depends on the person, and it depends on that situation. It depends on the age, I think, that she is, how long she's been in menopause. Has she been on hormone replacement? Is she used to that? Has she been on something for her mood for many, many years? And now that isn't, you know, likely to be that helpful for hot flashes, and we have to look for something else. The thing that isn't on here that sometimes is helpful is acupuncture. And for some women, you know, that can be really helpful as well. So I think we just have to, as Lori said, make sure we first rule out any underlying medical conditions, and then make sure we really listen to the individual patient, figure out what is the primary issue or trigger for that person, and then to help them, you know, with their symptoms.
And that's a great way of thinking about that, because it's not in isolation. So when you talk about bone health, which we've kind of already addressed, and adherence, we kind of get into this summary that it does take sort of that we're peeling back the onion, we're looking at assessment education, kind of those comorbid and baseline, and then what are the big issues that we're dealing with. So I think that we had a nice sort of overview of that, with a very common yet complex situation for many of our survivors. And then just real briefly, I wanted to highlight, because Dr. Day, you did cover earlier some cardiotoxicity in regards to metastatic breast cancer, but in general, we know that, you know, heart disease is still a very common event in women, regardless if they're breast cancer survivors or not. And our longer term survivors now have an equal to, especially postmenopausal or those over 65, they have an equal to or greater chance of dying of heart disease than their breast cancer. So as you're kind of thinking about this complex patient, of the baseline comorbid conditions, what happens because of therapy, and then things like weight gain, you know, how do you address this in the survivor, and what's sort of your thought process?
I think for me, it's first understanding, what that woman's baseline status of health is. Is this a woman who came already exercising 5 days a week for an hour a day, who was already, had a really high level of fitness and a good understanding of nutrition and those type of things? Or this was a woman who came to us, already 40 or 50 pounds overweight and is now motivated because of a breast cancer diagnosis to try to gain a new sort of level or improved health. So I think we have to understand kind of where we're starting from, work on setting goals, and then make sure that we're understanding the impact of all of the treatments that we're giving them, because often, exercise is something that will help. And so, establishing realistic goals, we often talk in my clinic about trying to walk for 10 or 15 minutes a day, and every few weeks try to go up by 5 minutes, just very slowly working your way up. But every time that you do that, you're going to not only improve your cardiovascular health, you're going to improve your bone health, you're going to improve your overall feeling in general, you're going to lessen stress hormones like cortisol, so you're going to sleep better. So all of those things are sort of connected, and we have to make sure we help them with all of those things.
Great. And it is complex because we're looking at them, and I like the term of this multi-hit because it is taking all those factors into account. And as they age and as they get farther away from diagnosis, the cardiovascular disease does become a equal or greater issue. Weight gain is very common, both we talked about for risk of primary cancer, but also as a risk factor for recurrence and new primaries. And so we do need to be using good tools and recommendations. We heard some from Dr. O'Day. Lori, do you have any go-to sort of resources or information that you provide to a survivor?
As far as healthy lifestyle and exercise. So I like to talk about nutrition. I talk a lot about healthy plate. What do you eat? I have patients keep a journal for me just of what they eat over a week time. And that I think is very powerful. It helps us to really dive into what they're eating, what choices they're making. I refer a lot of patients to support programs like Wellness Wins or Noom, something that has a psychology component as well to help them really decide why they're eating what they're eating and how they could change that lifestyle. Exercise, I encourage them to wear a Fitbit or get a pedometer. I do the same, it sounds like, with Dr. O'Day's patients in active treatment. We just try and focus on small steps. You're not going to lose 50 pounds in 2 weeks. And if we can lose even a pound a month, that's 12 pounds over a year. So I think, again, just slow and steady wins the race.
Go back to those SMART goals that we all know about and are hard to put into practice. So I also wanted to briefly just ask you, Lori, since you do have such a focus and experience in lymphedema management, we know there's some risk factors. We've already talked about those, but just thinking about it from prevention, are there things that the survivor or we should be encouraging our patients to be doing? And could you just give a brief overview of lymphedema prevention?
So the study of lymphedema has progressed so significantly over the last few years, especially with sentinel lymph node biopsy, decreasing the incidence, but it's still a potential complication. So just basic good skin care, using lotion every day, avoiding injuries to the skin if possible, avoiding the affected arm if possible with blood pressure and venipunctures. But really the biggest issue is weight gain and the pressure of the fat cells around the lymphatics. So again, weight loss can be a very significant prevention for lymphedema.
Great. And so we've heard weight loss is a common theme. It's probably the hardest thing we ask them to do, but it does have a great return on investment. We did mention that this patient had an updated CHEK2 mutation, and we're not going to go into what that means a lot because we just have a few minutes left, but it does lead us to potentially doing a little bit more screening in this patient and make sure she's also getting an MRI. But she does have 2 daughters that are 18 and 22. Oh, sorry. And so I think the important part for this is cascade testing as well. And so, Dr. O'Day, when you see this patient, like you said, you're encouraging them to talk to their family and so forth. How do you handle the daughters Do you go ahead and sometimes test them in your clinic, send them to genetics, or all of the above?
Yeah, really all of the above. It depends on if the family members, now live in the city or within proximity. Sometimes we do big group family sessions on Zoom or telehealth. Our genetics counselors are able to see people through telemedicine as well. And we can send saliva kits to their homes now. So it's very easy for us to help patients. And our main goal is just to make sure that no one falls through the cracks. Everyone who should get tested gets tested so that they can have the ability to be proactive with their health as much as possible.
Great. And cascade screening and testing has really become a very big priority in preventive care. I think we're going to just briefly end on financial toxicity, which Lori brought up in the intro. And the important part of this is that because so many patients are living with and through their disease, the phase of survivorship or continuity of care has become the most expensive part of our cancer care dollars now, which is interesting. And this is from the Office of Cancer Survivorship and Cancer Control as well. So I think there are some things we can think about. And, Lori, as you're thinking about this with patients with Dr. Day, we've listed off some potential barriers but some opportunities to dismantle those. Is this something that you would refer patients to financial counselors for? How do you kind of address this in that survivor population?
I think one of the most important things is understanding where the patient's coming from. And if they are having financial difficulties, or they're self-paying, or they're on an ACA platform, or they've lost their job, I mean, we just have to be very sensitive to that. We want to try and make sure that they continue their therapy if they're still on long-term endocrine therapy. So absolutely, financial counselors. We can get them set up with coupon cards possibly, or compassionate care. But I think it's something that we absolutely have to discuss with our patients. And we certainly don't want them to stop coming to the clinic, stop having their screenings because they've lost their job or they're financially at risk.
Absolutely. And I think you brought up a great point in that, we think so much about financial counseling and so forth at the initiation of treatment, but it really does need to be that ongoing sort of thought process for our patients. And we need to normalize that conversation. Like you said, it needs to be sensitive, but it also needs to be normalized so that patients understand that we talk to everybody about these types of issues. So I think that as we finish up, we hope that you have any other questions, please put them in the chat box. We've really kind of covered this gestalt of what it takes to really do comprehensive survivorship care. And anything that either of you would like to leave our participants with today in regards to kind of this cancer survivor in the middle and how we deliver care around them.
No, I think just making sure that we continue to support our cancer survivors, understanding that care is constantly evolving and changing. And so having patients be followed in some sort of a survivorship program, I think, is imperative, rather than just having them be, completely discharged and without anyone who's kind of keeping a pulse on what's happening in cancer treatment. So just for all survivors, we just promote them to be involved in some sort of a survivorship program.
Great. Well, thank you all for participating today, and thank you to our experts. And we will take any questions at this point.